happens once a month, typically on the last Sunday of the month, and it is organized by the Pakistan Society of Medical Genetics in collaboration with Dr. Saqib Mahmood from the University of Health Sciences, Lahore, and Dr. Rizwan Naeem from JSU, from the Jinnah. I'm just going to say the whole thing, Jinnah.
Jinnah Sindh Medical College alumni of
Thank
North
you.
America.
Association of North America. Thank you. So we are very happy that all of you are attending and giving us time on your Sunday evening. And with that, Aisha, can you switch slides so I can see what's on the next slide? Okay, so just a few pointers. Please stay muted throughout the time that the talk is going on. And if you have any questions, please write them down in the chat box. If there are questions that I can address, I'll try to address them there and then. If they're for Aisha, then we'll save them for the end of the talk and she will address them. Also, I will be putting in a link to a form, which is a survey on Google, several times in the chat. So please don't forget to fill that towards the end of the talk as well. Because that lets us know if you like the talk and that lets us know if you want to be involved in PSMG. So with that, I'm very, very happy to introduce Aisha. Aisha, I got to know, I've known Aisha actually for several years, but have worked more closely with Aisha over the last year or so. And she is just a very passionate and kind and amazing person that I've gotten to know. And I'm very happy, therefore, to introduce her. But she more professionally, she works as an oncology genetic counselor at Natera. She has over 5 years of experience of working in the rural oncology clinical setting. She's also very passionate about ethics and teaches a course on ethics in the genetic counseling program at the UCSD Extension program in California. She has a master's in genetic counseling from Stanislaus State University and is certified by the American Board of Genetic Counselors. So that is Aisha. She has a lovely picture.
Thank you.
You're welcome.
Awesome.
Okay, and with that, I'll just hand it over. Aisha, you can take over.
Great, thanks. Let me just switch settings. All right, wonderful. Thank you so much for the kind introduction, Myla. And good evening to everyone. Thank you for taking the time out of your really busy weekends to attend these lectures, and especially the one today. Before we, oops, sorry, my slides are changing on their own. Let me try something with the settings. Pardon my excuse here. Okay, so yeah, thank you for taking the time to come to our lecture series, especially today. But before we get started, I would like to clarify that I am a trained certified genetic counselor with deep interest in topics that we're about to discuss today. But I am by no means a jurist and clearly no scholar of religion. All the content of this lecture is from the lens of a genetic counseling perspective, and I am to present the information as it has been presented in books and peer-reviewed journal articles, the list of which will be available at the end of the lecture for your references. So let's get the show started. So before we take a deeper dive into the heavy duty topics of ethics and counseling, again, my slides are moving on their own, so I'm gonna have to switch back a little bit. Pardon my technology here. Let's see if I can do that. So again, like I said, I would like to set the stage for you and how we got to genetic counseling from a historical perspective. So in traditional medicine, a patient comes to the doctor for a proper diagnosis and treatment options, largely looking for some sort of a cure for their disease. For example, a patient is injured and is in need for a cast or crutches or painkillers, or a patient has an infection and they're looking for antibiotics, for example. Genetic medicine is slightly bit different. So while in genetic medicine, since the underlying disease cannot be cured, in majority of the cases, with the exception of recent development in CRISPR technology that can provide gene editing functionality, genetic medicine has largely been utilized for accuracy of diagnosis and management of symptoms, and not exactly a cure for a disease. So genetic disorders in their inherent nature are bound to connect multiple family members in their phenotype and symptomology. So this results in topic of difficult conversation, and rather difficult decisions need to be made in the patient population. In order to facilitate these discussions around the nature of disease, the risk associated with the condition, and what are the appropriate management options, in not something that traditional medicine is typically equipped for, which is really the educating part of the patient population. So enter genetic counseling. So genetic counseling is a process of helping people understand and adapt, to the medical, psychological, and familial / societal implications of genetic contributions to disease. This process generates interpretation of family and medical histories to assess the changes in disease occurrence or recurrence, education about inheritance and testing and management of the disease, how can disease be prevented, resources and research available to the patients at large. And lastly, counseling is used to promote informed choices and adaptation to the risk or the condition. And so now that we have set the stage and given you a little bit of background about what is the backdrop of genetic counseling, let's talk a little bit about the objectives for today. So that's where we would like to begin our show for tonight. We would like to start by discussing the fundamentals of ethics, followed by the difference between ethics and law, and how these ethical principles are utilized in genetic practices. And we will use the example of the National Code of, again, this is gonna skip quickly on me. So we'll go over the NSGC Code of Ethics, published by National Society of Genetic Counselors. We will delve into the psychosocial aspect of things once we have built that foundation of what is medical ethics. And then, let's see if this works. And then we'll talk a little bit about the theories of practical genetic counseling that we utilize on the daily as genetic counselors. And then lastly, we will discuss genetic counseling in Islamic communities. This information that I will be providing is largely based off of a paper that was published by Dr. El Hazimi in the annual Saudi Medical Journal in 2004 on the topic of genetic counseling in Islamic communities. And so that's going to be our little rundown for today. Okay, so ethics. So let's get started with the definition of ethics. What is ethics? So ethics really is the philosophical principles concerned with what is morally right and what is morally wrong in a given society. So ethical theorists have used the following 7 attributes or pillars when constructing ethical theories used in medical practice. These include principles that are your sources for guidance for our behavior, values that comprise of qualities that ought to be important and desirable in a society, rules that are specific guidelines for what should be and what should not be done by a member of a society, ideals that are goals to which we aspire or look up to, and then duties that are behaviors defined by our professionals or social roles. Virtues, these are morally and socially desirable characteristics, and rights are justified claims that individuals can make on a society. And so that takes us to a different topic. What is the difference between ethics and law? So law really just typically provides minimum standards of conduct. For example, the Medi-Cal Act of 2004 in the Pakistani constitution makes it illegal for a police officer, for example, to conduct an investigation on a person who is injured until medically advisable. But this law doesn't really mandate that every bystander in an accident location is liable by law for the well-being of the injured people or the injured person. This is more of a moral, not a legal obligation on the bystander. Laws are also not able to provide any clear guidance when it comes to some clinical ethical situations, or in certain cases, ethics and law can actually be in direct conflict with one another. So you can imagine that there could be actions that are permitted by the law, but they may not be ethically sound or maybe ethically controversial. You could also think of some examples where actions are permitted or prohibited rather by the law, but they're regarded as ethically defensible. And so with that being said, as a student of genetic counseling that all of you are now, you must be wondering, so when do genetic counselors really encounter ethical dilemmas in their practice, right? Isn't this very much cut and dry? And well, much like many of the medical specialties, a genetic counselor might face many ethical dilemmas within their careers. Typically, ethical dilemmas occur when equally sound arguments can be made to justify the application of more than one principles of ethics. So ethical theories are designed to help organize a genetic counselor's thoughts about various choices in such difficult situations. So next, I would like to talk a little bit about a case example. I know everybody loves a case example, so I'm just gonna read it out, and we're gonna come back to Mr. Ahmed's family actually a few times during this lecture. So I would like you to, if you weren't already paying attention, pay a little bit of attention here because this will come in handy in just a little bit. So I'm just gonna read it off. You're welcome to read it on your own as well. So here's a case example. Mr. Ahmed is a 40-year-old male with a strong family history of breast and ovarian cancer on his paternal side of the family. He has 2 brothers and no sisters. He is happily married, and he has 2 daughters, ages 26 and age 24. So his wife reads this article in New York Times by actress Angelina Jolie about her decision to have a preventative mastectomy because of a genetic test that revealed that she carried a variation of the BRCA1 gene that increases her risk for breast and ovarian cancer. So naturally, Mrs. Ahmed is considerably worried about their daughters and want to get them tested to find out about their risk for cancer, right? You would think that this is a simple example, but really if you read between the lines, this is rather a complicated case. Okay, so let's take a look at Mr. Ahmed's family history. So you can see Mr. Ahmed's right here. He has a brother. I know I said 2 brothers in the example, but for this space related issues, I had to cut it down to 1. So let's just say that he has a brother and he has 2 daughters. And you can see his mother is 65 years old, and both of the maternal grandparents have passed away with natural causes, heart disease, stroke, and things like that at old ages. But then if you look at his paternal side of the family, his father was diagnosed with prostate cancer at the age of 68. At 67, he's 68 now. So about a year ago or so, he has an aunt, a pupo, who was diagnosed with ovarian cancer at a rather young age of 40 and died shortly after the diagnosis. And his grandmother was also diagnosed with breast cancer and died within 2 years of diagnosis. So she died at the age of 47. And currently, he was recently informed by one of his cousins that his cousin through that aunt who had ovarian cancer is now undergoing treatment for breast cancer. So you can see that there's quite a lot going on and is really indicative of a underlying hereditary problem that is increasing the risk of cancer in his family. So how can we utilize this example and compare it to some of the principles that we have already been given from ethical purists and jurists? And in sum, I would like to go over 3 specific guiding principles. The principle of autonomy is the first one. And there's a very good reason why it's up top and center of attention. Autonomy involves telling the truth and respecting confidentiality. Beneficence and non-maleficence means to do good, be kind, avoid doing harm, and if harm cannot be avoided, to at least minimize the harm to the concerned individuals and families. And lastly, justice. Justice refers to all persons are treated fairly and equally, and they can obtain what they deserve and what they are entitled to. So let's go back to Mr. Ahmed's family. So in this case, who owns the genetic information? Is it the family, that the entirety of the family that owns it? Is it the individual that owns the genetic information? Is it Mr. Ahmed? Is it his wife? Or is it his daughters? And what about the right not to know in the context of disclosing genetics information to relatives? Do the underage daughters, or I should say they're not underage anymore, but let's say marriage age daughters, have a right not to know this information? And what about passive disclosure, non-disclosure? That's a term that's quite often used where patients agree that they will share the genetic information with their relatives in principle, but refrain from doing so in practice. Let's just say that the cousin who was recently diagnosed with breast cancer has the information. However, because of societal pressures or concerns, or just the fact that she's undergoing treatment, is not ready to share that information with the relatives just yet. Like I said, Mr. Ahmed's example is very, you could see that a clinician can say, hey, Mr. Ahmed or Mr. Ahmed's cousin, have you informed your family members? Or seems like there are 2 young girls in the family that would be very, very interested in this information. But he might say, well, yeah, I will, but, or she might say, I will, but they don't really actually go ahead and do that. So if we look at the roles of genetic counselors, so in this space, we're concerned about the daughters, we're concerned about Mr. Ahmed. What do we do as genetic counselors to facilitate this discussion and disclosures? So we first of all allow Mr. Ahmed and his cousin to exercise their right to privacy under the principles of autonomy. We explore the reasons why Mr. Ahmed is hesitant in sharing his information, or why is Mr. Ahmed's cousin hesitant in sharing the information, depending on who our client is. And then we offer the daughters a detailed genetic counseling session about their risks and what are some of the benefits of doing the genetic testing at various different stages of their life. Is 26 the right age? Is 24 the right age? Is 12 a right age? And so where do we go with that? So various different conversations we could be having to help facilitate. So, so out of the 3 ethical principles that I mentioned earlier, the principle of autonomy and confidentiality has really taken precedence and is used more frequently in making decisions as compared to the other 2 principles. This is controversial and frequently debated by genetic counselors and medical ethicists. Historically speaking, due to the private nature of medical and genetic information, maintaining control over who the patient shares the information with is an important part of the patient's rights to self-determination. We could say that patients also require assurance that their information will remain confidential in order to maximize full disclosure of their clinical information. A patient is very unlikely to share details of their medical history if they know that it can be used to harm them or their relationships. For example, Mr. Ahmed may share the information about his family history of cancer with a genetic counselor, or he may rather not share the information about his family history of cancer with a genetic counselor if he knew that the genetic counselor is going to share this information with his wife or with his daughters, and that perhaps might tarnish some of the relationships that he has. For example, while it would be in accordance with beneficence principle to alert Mr. Ahmed's daughter of their increased risk, ultimately the privacy of the information that Mr. Ahmed has will take precedence, or rather, even in this case, his cousin who is currently undergoing breast cancer treatment. So in the next few slides, we will cover the NSGC Code of Ethics in a little bit more detail. So NSGC stands for National Society of Genetic Counselors. It's an umbrella body for all genetic counselors practicing in the United States. And they published a code of ethics that attempts to clarify and guide the conduct of the professionals so that the goals and the values of the profession are best served. The document is actually divided into 4 segments. It includes code of ethics for genetic counselors towards themselves, towards their patients, towards their colleagues and other folks that they work with in the clinics and other professional settings, as well as code of ethics pertaining to the society at large. And so what we're going to do today is, in the essence of time, we're only really going to be focusing on the code of ethics towards their clients. And you're more than welcome to go to this website, and the source is at the bottom of the screen. You can see it, nsgc.org, and you can search for code of ethics, and you can read the other 3 on your own. But again, for the sake of time, we're focusing on the client part. So let's get into it. First of all, this is actually rather key to understanding code of ethics, is the ability for a genetic counselor to understand where they lack expertise, self-recognition of where a patient needs to get referred out is very important. And so referring the client out to an alternative genetic counselor even. So if I'm seeing a patient in cancer genetic counseling, but the patient really has prenatal questions, I may not be the right person. They need to go to a genetic counselor who is qualified and has experience in prenatal genetic counseling, as well as other professionals. So by no means genetic counselors call themselves psychiatrists. We are not trained to be psychiatrists. We are trained in psychosocial counseling techniques, and I will go over the difference between the two. And so refer out when a client is in psychiatric need is very, very important. Disclosure. Disclosing any real or perceived conflict of interest. In the beginning of my slide, I revealed all of the different places where I work and sustain my livelihood. And so you know that if I say anything, there might have been a perceived conflict of interest, and you're aware of it. Provide genetic counseling regardless of the client's abilities, their age, their culture, religion, ethnicity, language, sexual orientation, and gender identity. This is again based on the principle of justice to provide equal opportunities and facilities to all of the patients and clients. Also encourage clients to make informed decision free of coercion. So allowing the patient to tell you how they feel and which direction they're headed in terms of making a decision, but of course helping them facilitate that without any coercion. And also maintaining privacy and security of the client's confidential information is paramount, and to avoid the exploitation of clients' information for the good of or advantage of, or for sake of profit or interest for the genetic counselors themselves. So things like, using the data in some sort of ways without the patient's consent is unethical. This is one of the loose examples. So that's pretty much sums it up or covers the basic concepts of ethics and genetic counseling perspective. So next, what we will do is we will dive a little bit into the psychosocial counseling aspect of genetics. And I would like to start by just doing a brief definition of what is psychosocial counseling. So the term psychosocial actually refers to the interrelation of social factors and individuals' thoughts and behaviors. So how the two intertwine with each other is where the term psychosocial comes up. So in other words, you can think of it as psychosocial involves both the psychological as well as the social aspect of a person's well-being. So I hope that helped clarify the definition of psychosocial. So what are some of the issues that come up? So during a counseling session, not one of these will show up on its own, but probably a mixture of all, but it helps to categorize these different psychosocial issues that come up so that one can better understand and better address them in a patient setting. So let's start by going over grief and mourning. So grief and mourning, for example, could be where a loss of multiple family members, multiple pregnancies, multiple children has taken place. The patient is grieving of the loss of the loved ones and the ones that they were hoping to love one day. Current or future loss of personal abilities. So for example, a patient may have ability to do certain things prior to their genetic diagnosis that they're unable to do as a result of the inherent nature of the disease. So some examples that come to mind is parents of a child with Down syndrome who get the diagnosis after the birth and is actually grieving the loss of a typical child that they were planning on having during the 9 months of their pregnancy. Self-esteem injury is another one of the big things that come up quite often. This is injury to self-worth, self-dignity, and social standing and acceptance amongst the peer and the society at large. So take an example of an athlete who trained all their lives since they were children, and just to find out that they have Marfan syndrome that can cause severe damage to blood vessels coming from the heart if they continue to play this sport. And so you can imagine what kind of self-esteem injury that would do to an athlete, that they no longer can perform or practice their art, their sport. Guilt and shame. Guilt and shame is quite common in genetic counseling practice. We encounter this very, very often. You can think of guilt as something that is more inward, which is sense of self-responsibility, like perhaps I did something to cause harm to this child. Whereas shame is more outwardly. Shame would refer to feelings of exposure or judgment by others in the society. So an example that comes to mind is a mother might feel guilty for having a child who was short stature and is and feels as if she had done something to cause the child to be unhealthy. For example, did I not feed the child properly? All the while, the reasons could be something completely different, but she must be concerned that perhaps it's the lack of a good diet that is causing my daughter to have short stature. And so that comes up often. Shame could be where a father who might not take his son to a playground because his son can't keep up with other boys or other kids due to Duchenne muscular dystrophy. So that's outward, that's more of a shame thing. And then of course, every so often, this is one of actually my favorite questions that comes up, which is searching for meaning of life. It's rather philosophical and rather deep. And I love to have those conversations with my patients when it does come up, which is why did this happen to me? And why did it happen to my family? And so, so because of the nature of these complex concerns, it could really be manifesting in deep depression or anxiety and things like that, and even suicidal thoughts in very few rare cases. And so safeguards have been put in place for certain diseases where the number of suicide is rather high among individuals that are at risk for inheriting these mutations. Example, neurodegenerative disease like Huntington's disease. And so not genetic counseling and genetic testing plays a big part in diagnosing neurodegenerative diseases like Huntington's disease. Safeguards are in place to prevent the risk of suicide. So let's go back to our family of Mr. Ahmed. So I know I said earlier, pay attention because this will be coming up again. So here we are. So let's talk about Mr. Ahmed's family. In what ways could his family be grieving or mourning? Some of them are really obvious, right? So you see Mr. Ahmed has lost his aunt. He lost his grandmother at a rather young age. And now his father is diagnosed with cancer. So he may have already started the process of mourning and thinking that his father wouldn't make it, just like his aunt and his daughter or grandmother rather. Self-esteem injury is quite prominent in this family, I would think rather, especially Mr. Ahmed's father, who was the patriarch of the family. His mother died young, and so he then became the de facto parent of the family, for the lack of a better term. And he now feels that with his recent diagnosis, he feels sick, he feels ill, he's unable to do certain things, and that would definitely cause some sort of injury to his self-esteem. And guilt, of course, Mr. Ahmed might be feeling guilty because he could be blamed for his daughter if his daughters end up getting cancer and dying at a young age, because it's coming from rather, quote unquote, his side of the family. And the shame. So Mr. Ahmed might not want to tell the daughters or even his wife about the hereditary nature of this thing, even if he goes and asks the doctors and get the diagnosis himself. What if no one wants to marry my daughters because they might get cancer too at a rather young age? That becomes really, really important. And then the existential question, like I said earlier, is rather important to also discuss if and when it comes up, which is, why did this have to happen to my family? There's all these other families out there. Nothing's happening to any of the other families in my social circle. And here I am with my two beautiful daughters ready for a ripe age of marriage. And now I am faced with this very difficult decision to make. And so that's just one of the examples that I utilized in this talk. In different settings, different psychosocial concerns might come up. For example, in prenatal setting, one might anticipate adverse events. Before I jump into it, I want to take a minute to address this slide, just because it is really important to take a minute to understand that genetic counseling really takes place in two steps. It's usually a two or more than two-step process. First process is the pre-test genetic counseling, which is prior to usually a diagnosis being confirmed by doing a genetic test. And then one session takes place after the post-test setting. And this process usually takes an hour and a half, depending on the family size and the complexity of the issues going on. Usually we spend about an hour with each of our patients. And so now going back to the psychosocial concerns. So in pre-test setting, anticipation of adverse events. So if I find out that I have a high risk for a disease, for example, cancer, my life will stop to exist. And that is all I will be thinking about for the rest of my days. I could not comprehend that. Why would I want to do this genetic test? That might come up in a pre-test setting. Misconception of patterns of inheritance. This is quite common, where mothers are in our society and societies at large, even in Western societies, mothers are often the ones that get the quote unquote blame for a disease that a child might have, even if the inheritance pattern is actually autosomal recessive, where both parents are carriers. Or in cases of Turner syndrome, where paternal X chromosome is missing in 90% of the cases rather than the maternal X chromosome. But that totally is lost on the patients because of the lack of understanding of the, or misconception rather, of the patterns of inheritance. Fear of societal retribution. What if nobody wants to marry me? What if nobody wants to marry my daughters? Or will my spouse leave me and marry somebody else? Those are all the things that might come up in pre-test setting. And the right not to know. Again, cannot emphasize enough how often we talk to the patients that come in thinking they're gonna go and do a blood test or a saliva test, and they're gonna know their results in 4 days or 5 days or however long it's gonna take to get the results back. But rather it is a genetic counselor's job and role to enlighten the patients that they have the right also to know, but also the rights not to know if they don't feel comfortable, not ready, want to postpone or completely decline testing altogether. And then in the post-test setting, this is where family communication tools come into place. How do you speak to your children, your relatives about this really difficult situation? Genetic counselors write letters that can help facilitate this. They allow the relatives that are at risk to be on the phone while the patient is on in the clinic in person. So various different tools that we can use in communications. Sometimes anonymous letters are sent. Sometimes phone calls are made with genetic counselor being present, so they can have a mediator of sort in this conversation. Sense of relief or survivor's guilt is also very real. Once the genetic test comes back negative, a person might feel a sense of relief. Wow, I might have dodged a bullet, but also comes with that a sense of survivor's guilt. How come my sister or my brother had it, but I skipped it? It's quite common in genetic counseling setting. And then a sense of similar concern. So I know I had a concern, for example, which is very much like my aunt or my uncle, and I can relate to that. And it brings the families sometimes bond together over their similar concerns because they're going to see the same doctors, or at least the same types of doctors, going to have the same treatments options or management options available to them, so they find themselves in sort of a bond there. And then of course, support groups are instrumental in genetic counseling. Without a social support group resource, I would think that genetic counselors would be on wheelchairs. The support that we get as genetic counselors from our support group colleagues is invaluable in every sense of the word. And so when we think about a particular patient who's getting diagnosed with a hereditary disorder, they want to know who else out there has the same diseases I do. How can I talk to anybody who's gone through the same things that I have gone through? And can I share my concerns? In Urdu, we say, "Dard baat dete hain, to kam ho jata hai." And so this is one of those cases where if there are additional individuals that are out there that have same concerns as me, I might be able to feel a little bit better just by sharing my load a little bit. And so let's take a minute to talk about these counseling techniques that are used in genetic counseling. So you can think of these as our wrenches and our screwdrivers that are in our toolbox that we utilized almost on the daily. And so we really heavily rely on these, and I would like to share at least these 8. This is not an exhaustive list by any means, but it's definitely something somewhat of a very good list to start off with. So we're talking about tools like unconditional positive regard. It's hard to practice it, but like I said, with practice, all of these things come very naturally to genetic counselors. Unconditional positive regard for the patient and their needs. Empathy, and showing genuineness in your talk, in your tone, in your body language. Active listening, to really be able to understand what the patient is saying. The concept of active listening is very important. So active listening doesn't just mean that you sit there and you let the patient talk for hours and hours. It's rather understand what they're saying and compress it in a way and say it back to the patients so that they know that you were listening to them in a summarized fashion or in a way that is relatable to the patient. Normalizing the concerns. That's one of the biggest things that I use quite often, which is to say whatever it is that you're feeling, however it is that you're feeling, in whatever circumstances you're feeling, those are normal feelings, those are normal thoughts. What you're saying, telling me is not out of the ordinary, to be able to tell patients that their concerns are just as real. Reframing. So a lot of times, you'll see a lot of negativity. You can talk about, some of the things that I talked about earlier, and to be able to use their words and their language and try to help them see the good in what has been disclosed and what are some of the things that can be done, and how this information can be turned around from a negative to a positive. It's not easy and it comes with a lot of practice, which is why we will have a full course on genetic counseling techniques when we do have our full-fledged genetic counseling course. So it will all be discussed in a lot more details. Promoting competence and autonomy. That comes with a lot of education. You allow the patients to make their decisions based on their knowledge level. So when you're teaching somebody something who is at a PhD level, you talk to them differently. When you're talking to somebody who has a third grade education level, you talk to them differently, but allowing them and promoting autonomy to make their own decisions is very empowering, and patients actually really, really appreciate that. And then of course, social support. Social support, like I said, is extremely important in any genetic counseling practice. And so really there are two major, I would say, schools of thoughts when it comes to genetic counseling. You can think of it in terms of a non-directive genetic counseling, which is the historical concept that genetic counselors have utilized. And then you have the directive genetic counseling. Let's go over this just very briefly, if we could. So first of all, what is non-directive genetic counseling? Where did it come from? So historically, this concept was developed in direct contrast to the practice of eugenics, which was quote unquote cleaning of impurities in World War II. And so we know that we talked about this a lot in genetic counseling school, why do we have the way that we counsel patients in the non-directive manner? Well, it comes from the past, right? We have a very bad history where some group of people decided that a certain group of people was not good enough and needs to be exterminated and cleansed from the society. So non-directive in terms of the definition, it just means that non-coercive or non-prescriptive genetic counseling. So genetic counselors refrain from telling the patients what to do instead of allowing them to come to a decision on their own through dialogue and conversation. Also, in non-directive genetic counseling, it keeps the patients and personal and cultural and religious values in mind, and typically practiced in settings and disorders that lack clear guidelines of treatment. So a disease where there aren't, enough information to go off of in terms of proper treatment options, that's where non-directive usually comes in. Now, directive counseling is rather different. It actually historically was developed as more guidelines and more risk managements were being developed by the medical societies and by geneticists and other collaboration with other fields of medicine like metabolics or neurology or cardiology and so on and so on. And so directive genetic counseling could be defined as a clear, yes, you can do this, or no, you cannot do that, where a guideline is actually available. And so may or may not always keep the patient's values in mind. One loose example that comes to mind is if a patient has, some sort of cultural religious prohibition to organ donation. Well, a doctor will tell you that you have the option of doing a transplant of an organ, but it's at the end of the day, the doctor will not make that decision. The patient will make that decision on how to proceed. Typically practiced in settings or disorders where clear guidelines and treatments are available, like I said earlier. So that pretty much concludes our conversation about the techniques and tools that are utilized by genetic counselors. What we would like to go over next is genetic counseling in the Islamic communities. Again, like I said, I'm no jurist. I am no scholar of medicine or of religion rather. I'm a scholar of medicine, not of religion. So please. So genetic counseling.
I think it will be right. Let's know their genetic info on the side of the show.
Can I please request everyone to mute themselves? Thank you. So genetic counseling techniques emphasize to provide counseling in context of a patient's psychosocial reality. And since religion plays a vital role in the Pakistani society at large, an important aspect of comprehensive genetic counseling will include a study of religious aspects of patients' lives and the use of technology in their medical decision-making. This is one of the papers that I look up to all the time. It's a fantastic study that was done by Dr. El-Hazmi. He wrote this in 2004 and it was published in the annual Saudi Journal in their 2004 issue. And the title of the article, it sums it all up. It's Ethics of Genetic Counseling, Basic Concept and Relevance to Islamic Communities. So if you look at this table here, I've highlighted some concepts in green. So you can see here that in the Islamic teachings in the field of genetics, that's the title of this figure. And you can see that that is in Islam, under the umbrella of the emphasizing parts, you would see that autonomy, non-maleficence, beneficence, justice, confidentiality, medical responsibility. These are all the same concept that we went over earlier in our didactic lecture on ethics. So those don't tend to be not so different. Now, if you look at prohibitions in certain practices, you would notice that there are certain boxes that I have highlighted in blue and the others that I've highlighted in red. So blue means that there is wiggle room, there are some exceptions to the rule, and then the red ones are the ones that there's a hard stop and there's usually hardly any room to wiggle. So let's go over just a few of them. So for example, let's start with adoption. So in adoption, of course, we all know Prophet was an orphan. He was raised by his uncle and grandfather. And so we know that that's obviously a concept that's very common in Islamic societies. And so adoption of a child is actually not allowed in Islam only if the child's lineage, which is his or her biological children, is hidden or concealed from the child. So that's the only place where it really becomes not okay under the Islamic jurisprudence. When it comes to abortions, so there's a fatwa, and I'll just read out loud and I'll just quote what was in the fatwa so you guys can make a decision on your own what it means and what it doesn't mean. So in February of 1990, the Islamic jurisprudence of Makkah al-Mukarramah, the Islamic World League, passed a fatwa stating before 120 days of pregnancy counted from the date of conception, if this is proved and confirmed by a report of a committee formed of competent, trustworthy physicians, and on the basis of laboratory means that the fetus is grossly malformed with untreatable severe condition, and if he stayed and born on time, his life will be viciously and painful for him or his family. Then it is allowed to abort it on the basis of the parent's requisition. So that's the fatwa right there in a nutshell. And then when it comes to donor sperms or incest, that's where a hard line is drawn. Donation of sperm or ova or uterus is considered prohibited, as well as incest, where incest is defined as marital relationships between first-degree relatives, so brother, sister, father, daughter, things like that. So consanguineous marriages or cousin marriages. These are quite common in the Muslim communities and especially in Pakistani communities. If there are 100 of you today, this sounds like there are 63 of you. Let's just say there were 100 of you here today. 70 of you would have been in a relationship, a marital relationship with a cousin. So it's quite common in the Pakistani community, and it has a lot of advantages. We all know that there are societal advantages. We know that it strengthens family ties, maintaining ownership of the property within the family, payments of dowry, and better relationship with the in-laws. That could be very, very important for any family. Ease of finding a suitable partner. So you don't have to go looking out anywhere. The cousins, somebody you grew up with, you know them very well, helps in the not just the finding of the suitable partner, but also the longevity and the stability of the partnership. And of course, there are no religious prohibitions. There are no legal prohibitions in Pakistan for a person not to marry their cousin. So it's widely practiced. And of course, there are some evolutionary advantages for being carriers. So if a person has this doesn't really sit well with the concept of consanguinity, but in general, just speaking, at large in societies where we have identified a large number of people that have a certain carrier status, for example, cystic fibrosis, we know that in certain communities, people that were carriers for cystic fibrosis had resistance to cholera or typhoid fever or tuberculosis. And so it was to evolutionary advantage. And also we know that individuals that are carriers for sickle cell disease are resistant to the malaria parasite. And so there are some evolutionary advantages for being carriers. This may or may not always relate to a consanguineous marriage though. And then this is a graph that I really like, but like all graphs, no graphs are perfect or no charts are perfect. So I would like to give a little bit of a caveat before I go into this. So in this graph, you would see that they list a bunch of countries in the first column. Then you'd see the rate of congenital abnormalities in first-degree relatives, marriages, and those that were, first cousin relationships versus those that were non-consanguineous or non-cousin marriages. So I highlighted just three to make a point here. So if you look at the Pakistani population here, this is a study that was done in 1997, and you could see that about 4.5% of the time, children that were born to first cousin marriages had some sort of a congenital abnormality. So congenital abnormalities can be defined as a heart defect, a limb abnormality, malformation of the brain, and things like that. So those are more structural problems, not necessarily always referring to inborn errors of metabolism or neurodegenerative diseases that take place after the few years of baby's birth. And so keeping that definition in mind, it says 4.5% of the time, first cousin marriages result in some sort of a congenital abnormality, whereas in non-consanguineous marriages, it's about 2.1% of the time. If we look at a population in Iran, the study was conducted in 2007, so it's a much more recent study, where 7% of the babies born to first cousins were born with any congenital abnormalities as compared to 2% in the non-consanguineous marriages. And if you look at the Ashkenazi Jewish population or the European Jewish population of Israel, this study was done in 2008, you would see that about 12% of the time marriages between first cousin resulted in an adverse outcome, whereas only 2.7% of the time in a non-consanguineous mating. So you can see that for us, looking at just the shared numbers, you can see that, of course, even in non-consanguineous couples, the risk is not zero. And when the risk is not zero, obviously, you could say, I am in a cousin marriage and I have no problems with my children because, well, obviously 96.5% of the time, or rather 95.5% of the time, children are typical and don't have those concerns. And at the same time, you could say, well, so-and-so is in a non-consanguineous marriage, yet they also have a child with certain concerns. And that happens about 2% of the time. So, so the argument can be made either way. And there's, of course, no prohibition of consanguineous marriages, and it continues to be widely practiced in many communities and societies. So it's fact of life. So if we look at this map, which is the rate of consanguinity, we could see that in this map here, the Pakistani geography here is highlighted in the darkest because Pakistan has the largest, actually, sum of consanguineous marriages overall as compared to rest of the world. There are some sub-Saharan Africa regions like Chad that has a really high rate of consanguinity as well, but typically Pakistan and some of the other Middle Eastern countries tend to have the highest rates, as we all know it. Not to draw any conclusions from comparing these two maps, but this map is showing, sorry about that. This map is showing us the number of children that die in a country before the age of 5. So you can see that some of the sub-Saharan Africa countries, of course, have a really high number. You can see that they're close to 10 to 20% children die before the age of 5. And if you look at Pakistan, which is in light blue, which is close to this 5 to 10% rate of children that die. So of course you can't make the direct comparison because of course we all know that there's a lot of other things, including lack of medical facilities, infectious diseases. This could all be a contributing factor, and perhaps without knowing any further studies, perhaps consanguinity has one of those pieces of the puzzle. So that concludes my conversation about the Islamic communities and Muslim communities. But of course, Pakistan, as we all know, has a large ethnic and religious minority as well. And no competent genetic counseling workforce in Pakistan could exist without competent training in all of our ethnic minorities and religious minorities. And so keeping that in mind, that, you know, with the concept of justice and beneficence and non-maleficence, a genetic counselor ought to be trained in all different minorities, ethnic minorities, and their ethical values and cultural backgrounds to be a competent genetic counselor. And so with that, I conclude my talk for the day. Here are some of the books that I enjoy reading quite often. You're more than welcome to take a screenshot or a picture of the screen so that you could read it and enjoy it as much as I do. And I'm happy to take any questions or concerns that you guys might have. And then I'll.
Okay, thank you, Aisha. That was excellent. We have some really good questions, and I want to get them in. So the first question was from Dr. Saqib Mahmood. Okay. So this is a couple presented with bad obstetrics history. So the wife underwent 8 spontaneous abortions or miscarriages. So they presented for a chromosome analysis. The results of that showed a balanced translocation in the male partner, so her husband. Yeah. He does not want the genetic counselor to share this report with his wife. Yeah. Would it be ethical not to inform the wife when the cause of her miscarriages or spontaneous abortions is due to the husband's genes?
That's an excellent question, Dr. Mahmood. And this is not something that is rare in genetic counseling. It's actually very common in genetic counseling. And so I'm glad that you brought up that question. And so let's talk about some of the concepts. So if you look at the beneficence and non-maleficence ethical theory, of course, there is great harm being done to this poor lady who continues to have these miscarriages. And without really knowing why this keeps happening to me, it's kind of, it's really rather devastating. But if we look at the guiding principle of autonomy, it is rather the male partner's personal information that he owns, or he is, I should say, he is the keeper of. And so the conversation, this is where a genetic counselor becomes so important. The conversation needs to be had with the male partner in order to extrapolate what are some of the reasons, what are some of the underlying causes as to why he is so keen on not telling his partner, who continues to have these miscarriages. He definitely loves and cares for her tremendously, which is why they have had 8 pregnancies. I mean, something must happen in order for a pregnancy to take place, some sort of intimacy. And so in this situation, the genetic counselor will go into a deeper conversation with the partner, figure out what are some of the reasons, and then of course, encourage but not coerce them into telling this information to his partner.
So Aisha, this is Dr. Rizwan. So
Hi.
follow up on this question. So if the case was other way around and female partner is a carrier of a translocation, and her question is that if I tell my husband, he'll give me divorce. He will divorce me. So how do you deal with that? I think these are very difficult questions, but very important.
Right. Don't discriminate between the male and the female partner. Again, do the exact same process that you would do for a male partner. It is still, again, understanding the reasoning behind why, talking to them about it, telling them what are some of the risks and benefits involved in keeping this information and not keeping this information, and allow them to make that very, very difficult decision to not share the information with the male partner that and in their society, in their relatives and their immediate family members. They are the best judge of who and how the information is shared. So to answer your follow-up question, the same steps would be followed, which is to have a conversation with the female partner alone without her male partner, have her understand the risks and benefits, and allow her to make the ultimate decision.
Hi, Aisha. This is Salman Kirmani. So I just had a quick thing to add. If appropriate pre-test counseling is done, and if both the partners, the male and the female partner, are there during the counseling session, then I think you can sort of circumvent this problem, because then both of them are equal partners in the decision-making process, and you make sure how and when you will do the disclosure of results, and you anticipate what you will do if it's positive and what you will do if it's negative. I think we run into these problems when we cut corners in pre-test genetic counseling.
Very good scenario, Dr. Kirmani. So there is a concept for group counseling, what I'm talking about. So family counseling or couple counseling. So if a test which is benefit or have consequences on both parents, then it is more advisable probably to do a couple counseling.
Right. So like Dr. Kirmani mentioned, the pre-test counseling is paramount importance. A patient who knows why they're getting into this test, instead of just giving them the results in piece of paper and saying, here you go, these are your results, figure out what you need to do. That's ethically not sound. We need to be able to have a conversation with the couple before they do the test, so they can understand, here are your possible results. Are you still keen on undergoing this genetic test? And if so, let's have a plan of who we're going to discuss it with, who is going to be the recipient of the result, and how should we go about doing that, and have this detailed dialogue as a planning session before the test is even conducted.
Okay, so next question, Aisha, is from Sanila Khan, and it's a more broad question. She's saying, what are some specific ethical issues unique to the Pakistani population when dealing with psychosocial counseling after genetic testing?
Yeah, excellent question there as well. From the brief stint that we have had from the past 6 months of genetic counseling patients in the Pakistani population, the biggest psychosocial concern that we have encountered is that of marital relations. So-and-so is not going to marry my child, or my daughter is never going to get married, because if everybody finds out that she has a hereditary disease, she's done for. And those are really hard cases. We talk to these patients in detail about risks and benefits of marriages and disclosure to the future or potential in-laws. And again, it's all about having a deeper dive into the conversation. So that's one thing that has come up. The other thing that has come up is, so I would say the feeling of guilt has come up very often, and this is quite often in mothers. We have had fathers who have also expressed guilt, but quite commonly, female partner is the one that attends these counseling sessions. So in most cases, it's the female partner we're dealing with, but we have seen guilt as one of the most common things that people feel remorse and have negative thoughts towards it. So those two have come up, but again, our stint has been so short, so small. We need to do so much more in terms of data collection and these psychosocial issues. I would say, Dr. Kirmani, if you could please say a few words, just because your experience is so much more than any of ours combined when it comes to psychosocial concerns. So if you can take a couple of minutes.
Sorry, Asha, I missed the first part of the question. So if you can just repeat what the exact issue was on the first part.
Yeah. So,
yeah, I can repeat it. It was, yeah, what I guess just mentioning some psychosocial concerns that are specific to the Pakistani population.
Oh, okay. Thanks. Well, there's so many. I think one can write a book on it, and I think one should. There are so many, and one of the main ones I think that we struggle with, that maybe people in the US don't, is not so much a Pakistani issue, but more of an economic issue. When people are paying for a genetic test, out of pocket, and the expectations are that this is going to answer all the questions, open all the doors. The expectations that are set are way too high. And what I struggle with on a day-to-day basis is, if I give them a very, very realistic picture of what the genetic test can and cannot do, a lot of them say, why should I bother?
Right.
And if you don't give them a very realistic picture, then they're all for, oh, let's do it, and then they don't get appropriately counseled. And I think one of the challenges that we face is that in a very, very busy setting, all of us in Pakistan, whatever clinical setting we are, we're terribly busy because there are too many patients to be seen in a very, very short time. And it's so hard to maintain your poise and, to hit all the appropriate points in counseling. So I think that's because that's a big one. And there are many, many others, but I'm going to touch on that one because that one is something that maybe Aisha hasn't touched on in her excellent talk that she did.
Yeah, thank you. Other questions, Marla?
Yes. So my next question, again, it's a really good question from Dr. Saqib Mahmood. He's asking if you know anything about pre-implantation genetic diagnosis according to Islamic ethics.
Yes. So again, I'm no jurist, and if there are any jurists or Islamic scholars on the call, please chime in. But from my understanding, which is limited, is pre-implantation genetics diagnosis and in vitro fertilization are permitted as long as the fetus is grown in the mother's womb and the egg and the sperm utilized is from the partnership which is in the marriage. I hope that answered your question. Other questions?
So, but I want to add to this very interesting question. I think when Islam was, came in practice 1400 years ago. And at that time, there was no such concept even what is in vitro fertilization is, what is pre-implantation genetic is. So you can look into principles that do no harm, for example, right? And if someone is struggling or is in pain, share or cure that pain or cure that disease. And if we follow that diagnosis, that principle, I think we can devise. There may be different thought processes for this, but I believe that the best will be to follow the principle rather than putting something on saying that this is what is allowed in Islam and this is what is not allowed in Islam, because at that time there were no such concepts.
Thank you, Rizwan, for chiming in. Of course, like I said, no two Muslims will have the same, I would say, clarity in their minds about what to do in certain situations. These questions are probably best addressed by an Islamic scholar or somebody who is more into the jurisprudence and studies of such kind.
Okay, so next question is from Ansar Rabia, and she is saying that if there's a child, supposing a firstborn who has some sort of maybe a genetic disorder, and genetic testing is done, and only it sounds like one of the parents wants to really know the results, and the other one doesn't. So what should be done in such a situation?
You're throwing all the curveballs at me today.
They're good questions.
Very good question.
Right. I don't know. I don't have a very good response to that. That's a tricky situation. Of course, if a geneticist or a genetic counselor is getting the referral for a diagnosis of the patient, of course, that means that the pediatrician really needs to know what's going on and what is the underlying disease and how to manage this disease. And without a proper diagnosis, it's not possible for a proper management. And so for clinical reasons alone, a geneticist would then have to have a conversation with the parents and help them understand why it's important for a genetic diagnosis, not only for the management of current symptomology, but also for any of the upcoming and future anticipated symptomology that will show up in the future days to come. And so again, you know, it's all about conversation. It's all about having a dialogue, and having all parties involved is mostly important. But again, when it comes to our society here in the United States and North America and other European countries, you know, the fact that a child needs to have a diagnosis takes precedence.
So I want to add to something what Ansar's question was about. One parent wants to reveal genetic testing information and other doesn't. So I think Dr. Kirmani has addressed that very well, that if you do a pre-test counseling with the couple together and let them understand the consequences is on both, not single parent, I think you can circumvent that question. And the second part, answer is that the research setting. That's a very important question. So research question is a research question, not a diagnostic question, not a treatment question, not a counseling question. That can be published without information, but none of the research studies, research findings should be shared as a diagnostic finding.
Yeah, I'm sorry, I missed that. That was a part of your chat conversations, but yeah, research setting results are not revealed to anyone, even if it's for the parents or the child or for diagnosis, it's not revealed.
Thanks, Aisha and Dr. Rizwan. So I can add to that. I think there's been some recent changes in the way researchers now can disclose results. And I think it's really important because I don't think there's one rule. There are some researchers that will say upfront that we are not responsible for disclosing any results. And you know, the clinicians who are signing up their patients for the research study, you know, when the participants sign the consent form, they should know that they are not going to be disclosed. They are not going to be given results. If results are going to be disclosed, then it's very clearly stated in the consent form and in the research protocol who will deliver the results, under what setting will it be delivered, will they be confirmed in a clinical lab or not, and all those things are kind of all preset. So again, if all the homework is done beforehand with the research studying, which now I don't think any IRB or ERC will allow any genetic studies to happen without that specific point being addressed, I don't think you're going to run into any problems.
Yeah, that's an excellent point. And I think, sorry, I'm sorry, I didn't read your question correctly the first time because I missed out the research part of it. But I guess, and correct me if I'm wrong, Ansar, but you're trying to see that supposing this IRB, the consent initially stated that results would be disclosed. So that was done on the front end, but then one of the parents wants to know while the other doesn't. Now I'm thinking I'm really getting at your question, but I feel like that has been addressed a little bit already, just in terms of, again, pre-test counseling or consent for research in this case. And then later on, sort of just discussing, if you're in that situation, with the parents of what needs to be done next.
Yeah, and I can add, I'll be black and white there. If one of the parents who signed the consent form or the assent form for the participant is the one asking, and we're allowed to give them results, we can give them results. If the parent not signing is asking, I think that's the issue. And at that point, I guess, we'd have to ask the parent who signed the consent form, because legally you are bound to the person who signed the consent form.
So, my question is again to Dr. Kermani is this, that if you do that type of setup where you have written good documentation and make patient signs, and they're done in English and people don't even understand English, and they just sign most of the consent, you read the policies we signed without knowing what it is. So is that fair with that population, that to have that complicated or what you call protocols, and which patients may not even understand, not in their own language even?
Right. So that's why, Dr. Rizwan, we have to have them sign a consent form in Urdu. So
Right.
no research study in AKU can happen without a research consent form being translated into Urdu, and that also simple Urdu so that patient can understand it.
That is wonderful. That is good to know. I did not know.
If they're Sindhi or Punjabi and that's the regional language, then it has to be translated into that regional language.
That's a wonderful initiative. Thank you.
Any other burning questions, Myla?
So we have some good comments in the chat. And then let's do the last question, unless someone else has a question that they really feel like they need to know the answer for. The last question is, how do you counsel patients? So this isn't really specific to yours, it's a really general question, but how do you counsel patients with no knowledge of genetics? Where do you begin?
And another excellent question. When you take the course in genetic counseling that will be coming to you soon in fall of 2022, we will go into in-depth conversations about how do you talk to individuals that are health illiterate. You don't even, in some cases, you could have a patient who is extremely knowledgeable about their field of interest, like engineers and commerce and music and things like that, but have no knowledge in genetics at all, or medicine in general. And so we have tools, we have mock sessions, and we have so many different ways in which we were trained as genetic counselors to be able to have a conversation with individuals of different learning parameters or learning abilities, and see how we could communicate information to them so that they can make an informed decision. It's doable. It's very hard, but it's definitely doable. If you are interested in any resources, you could always Google search for, I think they just recently changed their name. It's now, I think, Medline. But if you look up genetics home reference and the particular disease that you're interested in, it gives you, of course, it's in English, so you have to start with translating it into Urdu on your own. But that's one very good place to start in terms of basic concepts of genetics and diseases and things like that. So if you're interested in, let's say, Turner syndrome, you go to this website and you look up, say, for example, Marfan syndrome, like Myla just posted, or Turner syndrome, and it'll give you a very, very rudimentary, in simple words, in simple English, what is the disease and what are some of the underlying hereditary concepts. And then you can use those and translate them into Urdu or regional language and help address that with a question. But it really is a skill set. It's an art, it's not a science. And it comes with a lot of practice. And so, right, of course, we will spend a lot of time talking about it in our course when we offer this genetic counseling course. Stay tuned.
And Aisha, I can add to that. That's an excellent question. And I think that's the beauty of being a genetics professional, that you are a teacher first and an advocate, and then a medical provider. So I think it's really important for anyone who thinks about doing this in the future is that this is not something you can take shortcuts at. If it takes you an hour and a half to explain something to that family in front of you, you should take that hour and a half, because that's what they deserve. It's you have to do it, and you get better at it with time. I learn every day, and you learn to see what people want and what people get, how they respond and what they do, what words to use, what words not to use. So many regional and cultural nuances even within the Pakistani population. So like I said, I think once this course is designed, there'll be so much interaction with people who are already here on the ground that I think we can actually come up with actually sort of a handbook of resources where people can share their experiences. I'll give you a tiny tidbit. When people ask me कि आप किस चीज़ के डॉक्टर हैं, right? So when you say genetics, it doesn't make sense. So you can say कि जी पैदाइशी अमराज or something, but sometimes even that doesn't make sense. So if you use the real proper Urdu term, it's जीनियात. तो अगर आप ये कहें कि जी मैं जीनियात का डॉक्टर हूँ, तो कहते हैं आप जिन्नात के डॉक्टर हैं, हम आपको नहीं दिखा रहे. So these are little things that you laugh at the time, but it's one of those things where it can really break your relationship with the family if you didn't appreciate that you were someone else and what your role was. So I think we struggle with that a lot, but I think that's where all the hard work has to be done. And I think that's where this society can actually contribute something very unique, is to bring all these shared experiences together. People who have been doing this for 20 years in an informal way may have certain pearls of wisdom that you and I don't have. And I think sharing those and bringing those forward will be very, very important.
Wonderful. I'm so glad that you're here today, Dr. Kirmani, because your insight is so invaluable. I was just going to say that, this question actually is not only a question for the Pakistani population. We in the United States have, some of the most literate individuals, yet we struggle with telling people what we do sometimes. And so to come up with the vernacular and the vocabulary that is translatable to colloquial English it's tricky, and we work on that. We practice that in genetic counseling school, and we talk about, when I talk to my grandma, what do I tell her? When I talk to my mom, what do I tell her? When I talk to my sister, what do I tell her? And my friends and colleagues, what do I tell them? So yeah, no, definitely a good question. Any other questions, Myla? We're running almost out of time.
Does anyone else have any questions that are specific to Aisha's talk that they would like to be addressed in the next couple of minutes? And please put them in the chat. Okay, so we have one. If you are doubtful to have any genetic disease in your family, what to do in case of Pakistani society where there is no one to understand this necessity?
Broad question.
Yeah.
I would start off by just saying that it comes with awareness. We have some really wonderful people that have already done the really hard work. Rabia Rizvi is on the call today, and she has done some amazing work when it comes to just awareness of special needs children. And that's where it really starts on a broader level, a broader society. I know Dr. Kirmani has done some TV shows about Down syndrome and other concerns, and he and his team does a wonderful job of doing some of that. But of course, when a family comes to you, they are your focus of attention. You need to be able to explain to them these hard concepts as a genetic counselor. You need to be able to address their psychosocial needs. And like Dr. Kirmani said, no cutting corners. If you have to talk to 5 different family members at 5 different times, then be it. That's where it needs to be done, and there has to be a place to start the conversation. And I'm going to be quite frank and honest with you. We have had few genetic counseling sessions in Pakistan with some underprivileged, low socioeconomic status folks at the NICH under the guidance of Dr. Jamal Misbah. And if she's online, she's done some excellent work with us. And Dr. Mohsina, who's doing some wonderful work in endocrinology at NICH. We have talked to people, they have understood the concepts, they have taken it with stride, and are better for it. If Ms. Bowe, you want to say a few words about the post-counseling reactions and intervention, or comments that people have passed to you? We just have had of course, from our sample size is so small, we cannot possibly say that it can apply to everyone. Well, we have had an encouraging time or encouraging interactions with the patient populations in Karachi so far.
Okay, very good. This was a very engaging and informative discussion. Thank you, everyone. Thank you, Aisha, for presenting, and thank you for all the excellent questions by the attendees and the really good comments. With that, I'd like to end. Oh, one last comment I just want to put in there. It was very nice. It was towards the end by Dr. Mahmood that he thinks that even people who are illiterate in Pakistan somehow relate to genes and genetics, specifically those who are involved in the agricultural and domestic animals. So that's an excellent point. But with that last comment, I'd again like to thank everyone for the organizers.
The survey, Myla, I just wanted to.
I've sent the survey link multiple times in the chat, and I will do it one last time. So if you haven't had the opportunity to fill it out, please do fill it out. It gives us information about who attended, and it gives us information about what you thought about this talk and just who you are. Also, this will be an ongoing lecture series, and it sounds like this time works out for everyone. So it's going to be the last Sunday of the month, and this will be the time. So we will look forward to seeing you for the next one. There will be some flyers that will be the topic, or do we know the topic for the next one that we can share at this point?
Most likely it's going to be a laboratory genetics.
Okay, very good. So it'll be focused on laboratory genetics. So stay tuned and we will send those flyers out. Thank you everyone for attending and engaging in the discussion.
Thank you.
Thank you. Bye-bye.
Banda tatlı bir var. Banda